Next speaker is Dr. Michael Stirratt, who is a scientific program officer at the National Institutes of Mental Health Division of AIDS Research, where he leads a portfolio of federally funded research grants around treatment and prevention adherence. And want to say over the last decade, Mike has been instrumental in shaping and changing the direction of adherence science in HIV. So I think a decade ago, it was, as we've done most today, talked exclusively about pills and medication taking and adherence and persistence. And the field of HIV has shifted to look at adherence to care, that half of our folks diagnosed with HIV aren't in care. So before adhering to pills, you have to actually get linked to medical care and be retained in medical care, as well as adherence to prevention strategies. So in the HIV adherence space, it's really changed dramatically and dynamically the last decade, and Mike has had a huge influence on that scientific agenda. So a lot of credit to him. Also, I didn't realize until planning the conference that we're really lucky that Mike serves as the co-chair at the NIH, where they have an adherence network. So a consortium of 17 NIH institutes, offices, and centers that come together around adherence. So it's great to welcome him to talk about the NIH perspective on adherence. And more broadly than just HIV to across kind of the NIH. And on a personal note, want to say it's fun to welcome him back. So he first came to visit us about 10 years ago and has been a frequent visitor to UAB and a great friend to UAB. So it's always such a pleasure to welcome him back to Birmingham and look forward to your talk. Thanks for coming.
Well, thank you very much, Mike. That's very kind. And my phone. It's always great to be back here in Birmingham. I have been here several times, and it's great to be here again with you today. I think many of us in this room are scientists and practitioners, and as a result of that, we're very much impressed and swayed by evidence. And when I look at this room and I see the number of people who've come here today to share time and think about the issue of adherence, I think we've collected some powerful data indicating just how cross-cutting and important this issue is. So it's a real pleasure to be with you all today and to think with you a little bit about this challenge. I also think that you'll see that there's some interesting synergies between all the talks this morning have been uniformly excellent. And I think there are some synergies between what those talks have said and what I might have to say as well. That's good too. I think it suggests that there's already some directions that are coming out of this meeting. So I'll just jump right into it. To give you a little overview of where I'll go, I want to talk about our approach to adherence in terms of how we think of it and its definitions, and also understanding it and then addressing it. And what I will highlight is, at least just briefly, how adherence is really a multi-component concept, and also that it does require more than medication taking, which Mike just made a reference to. I'll talk just very briefly about understanding adherence. Reve had a great talk about the models this morning, but I want to highlight the idea of intentional versus non-intentional adherence, as well as the idea that we have multi-level determinants of adherence. And then finally, I'll close to talk a little bit about how we need to advance the evidence base around effective adherence interventions and monitoring of adherence, and the role that you can play in terms of your research and the NIH opportunities that we have available to you to advance those efforts. So we'll just start with defining adherence. This is one particular framework that's been used to understand the issue of medication adherence. It comes from Bernard Vriens and a group of people who are working on adherence. It's a European association, ESPACOMP. And they identify adherence as a very broad term which encompasses different ways that patients can take their medications. And we've already heard a little bit about this morning. In particular, they think about three components, that there's initiation, implementation, and persistence to a medication regimen. And so in initiation, one has to actually begin to take the medications. And it's interesting, the receipt of a prescription does not necessarily guarantee that that prescription gets filled. Then there's the implementation, and that's where we often think about adherence in terms of daily dose taking. What percentage of pills that were prescribed and filled, what percentage were actually taken? And then finally, there's the issue of persistence, persisting on adherence over time, and taking those medications over longer intervals. What we have really is an interdimensional concept of adherence, and there's challenges at each one of these different junctures. So this is a review which is looking at prescription initiation, which has been called primary adherence. And what you find is that across a whole variety of drug classes, as well as chronic illness areas, you actually have about a quarter of patients who never initiate their prescription. And that varies. Here it's higher in some places, lower in others. I think it's least high. Let's see. You get the best initiation, I think, for pain medications. So it's interesting to think a little bit about what motivates people to actually fill those scripts. But anyways, we do have a problem here with people even just getting off the ground in terms of their regimens. Then beyond the initiation, there's the implementation of these regimens. And this was a review which was also mentioned earlier today by Di Matteo. And what we find is that implementation is also a problem. In this meta-analysis of more than 500 studies, they looked at different kinds of health-related behaviors. And when it comes to medications, the average percent adherence in terms of doses taken was about 80%. So roughly 80% of doses are taken, 20% missed. It's interesting, though, to also look at this review and to see adherence in other aspects of healthcare and health behaviors. In fact, medication adherence may do somewhat more favorably compared to these other areas, such as exercise, appointment attendance, and then certainly diet. And I know that I have a real trouble. Adherence to a diet is definitely a challenge for me. I will confess to that. But anyway, so we have to remember that adherence is not only multi-component, but it's also about much more than just medicines. It's also about these other indicated, recommended healthcare regimens. Then finally, there's the persistence problem, which has also been highlighted this morning. And here we have, a couple of different, or a few different areas of work. And what we find is that roughly 40% of patients across conditions discontinue their medication within a year. And there are some subtleties to that. Some may reinitiate if a different drug or a different class, but nonetheless, we have some problem with persistence over time as well. I mentioned these kinds of things because when it comes to thinking about the different components of adherence, this really requires us to make some informed judgments about the kinds of measurements that we use. And especially when we're looking at studies, how we compare studies, it may be that each one of these aspects, initiation, implementation, and persistence, has different kinds of measures that are better or not so good in terms of their assessment. And it may also be that they each have slightly different determinants. And that if we really want to work on the issue of initiation, it's possible that those interventions are slightly different than the interventions that we do around implementation, for example. So something to think about. But then we also know that adherence is more than medication adherence. And we go back to this original definition of adherence, which comes out of the work by Haynes, which is the extent that a person's behavior in terms of taking medication, following diets, or executing lifestyle changes. So when this was first talked about in this seminal piece, really thinking about it broadly, not just medications, but other healthcare behaviors. And of course, we have a variety of words that get used to represent this area. And it is true that it represents efforts that we need to address in both treatment and prevention. But so as we saw here, in this analysis, we see a variety of levels of adherence, at least at the average level, across these different kinds of health behaviors. But then there's also the larger context in which people engage with their health care. And so, this is work that, it does come out of originally the HIV field, but the idea that there's a sequence or a continuum that people have to travel through in order to obtain the benefits of treatment. And in this work by Tom Giordano, early effort in the HIV realm, the idea was that if people are living with HIV or they have HIV infection, they must first learn that they're HIV infected, then they have to be linked to HIV care, they have to utilize the services there and adhere to the care. And the care involves both adherence to appointments and adherence to medications. In HIV care, typically people are seen maybe once a quarter, to do clinical monitoring. It might be somewhat less if people have achieved, a certain level of stability. But you need to not just take the medications, but you also have to come in for those medical care appointments. And it's very interesting. So huge attention in the HIV field to this idea of an HIV treatment cascade. And to only briefly walk you through it, if you kind of look at the bottom here, what you have is that series of steps in the HIV care continuum. First, you need to be HIV diagnosed, then linked to care, you need to be retained in care, you need to receive a prescription, and then finally you need to take that prescription and adhere well enough to it to benefit from the medication, to become virally suppressed. And what Ed Gardner and others in the HIV field have helped us to understand is that we wind up losing people at each point of this process. So the treatment, it's a cascade, because you see that the bar keeps falling down at each step. So if we think of, this would be 100%. If we think of all of the HIV-infected individuals in the US, 1.1, 1.2 million people, only about 80% receive a diagnosis, and then only about 62% actually get linked to HIV care. They're not all retained in care. That's a major problem for us in this area. And then they don't all get a prescription. And finally, not everybody takes their prescription as indicated. And so what you have is that in the end, at this cascade of all of the people living with HIV in the US, the current estimate, which might be going up if they have fresher data, is that only about a quarter, maybe a third of people living with HIV in the United States have viral suppression. And it's because of these aspects of the care continuum. And really, you can think about adherence along this continuum. So we want to see that people get tested regularly, that they're being screened, that they are linked to care. That's kind of an initiation issue, and that they're retained in care as well. So there's aspects of adhering to the larger sense of care and not just to the medication regimen. And so just to put that all together, we might think about two areas for our therapeutic adherence concerns, and one is adherence to the drug, acceptance, implementation, and persistence. And then there's also adherence to the care. And that involves linking to care, having regular appointment attendance, and being retained in care over time. So there's both the drug use as well as the wider context of care engagement that's important to think about if we really want to take a multi-component and broad understanding of adherence. So just briefly, I'm trying to we're at the edge of chaos here, so we want to try to do our best to understand adherence. Revé's spoken powerfully this morning about different kinds of models that can be used, behavioral models that can help us to understand the determinants of adherence, so I won't go into that in any depth. I did want to just note this idea about intentional and non-intentional adherence, and I think this came up in some of our discussion this morning. This is a project that followed folks for 1 year after acute coronary syndrome, and they used a measure, I think it's called the MARS instrument, and they were looking at whether people were missing doses either unintentionally, they just forgot, they happened to miss their dose, or intentionally, they had decided to discontinue treatment or that they didn't want to take that pill because they just thought it wasn't a good idea. And what you actually see is that, over time, a huge proportion of the people who have an adherence problem have some kind of unintentional adherence. They've forgotten to take their pills or something got in the way. But there's a proportion of people, 15%, that is intentionally saying, I do not want to take that. They've decided they're not going to take the pill for one reason or another. And it's important to mention this because if we want to understand adherence and think about ways to address it, again, we might have to think about different kinds of interventions. If the primary issue for somebody is that they're forgetting things, reminders might work. But reminders are not going to work for somebody who's decided that they don't want to take their medications. That's going to be a different kind of intervention that we're going to have to affect. Additionally, this has to be wrapped in a larger context as well. This is a piece from the WHO where they think very broadly about the multi-level determinants that influence adherence. This, for them, they identified 5 factors which, get at this issue. It starts, with things like patient-related factors, and we've talked a little bit about this morning, knowledge, behavioral skills, motivation, but it also relates to the drugs themselves, the characteristics of the treatment, side effects, complexity of the regimen. And there might be aspects of the disease itself. I do a lot of work in HIV, and so HIV has an illness that has a lot of stigma that comes with it, and that can challenge adherence. But then there's also the patient-provider communication, which we've heard powerfully about this morning, as well as kind of a larger systemic context where people encounter financial constraints or other aspects that might limit their ways to engage in care. And so we do have to kind of think about this larger piece when we're trying to program our efforts to improve adherence. And if the idea is that adherence has multiple determinants, to assemble that puzzle and really put all the pieces together, That's the only way that we're really going to get to a good solution. So the solution is really going to require working on every one of these levels. So then let's talk about responding to the adherence challenge. There's, in a way, what's suggested, and I think what we've heard is that we might require an ecologic approach to adherence. If there are multiple levels of influence on adherence, we might need to think about intervening on multiple levels to optimize it at its best. And that starts with our regimens. We want to do what we can to make regimens simpler to take, to reduce the burden of adherence. Long-acting regimens are an interesting idea. But that's probably helpful, but maybe not enough. Because we also have to work on these other levels. What can we do to help patients, individual patients, have the behavioral skills and the capacities to adhere? What can we do with providers to improve their communication with patients and the kind of quality of care that they deliver? How can we intervene in healthcare systems themselves through modifications in EHRs or the way that we address things like healthcare coverage and copays? And then the community context. How can we work on issues like stigma and discrimination that present challenges to engagement in care and treatment adherence? It's going to be hard to do all of these things at once, but we can work on either one level or sometimes multiple levels, and that might be a way forward. How are we doing on this front? Well, if you read the Cochrane report, it's pretty, it's disappointing. And there is the idea out there, to be sure, that there's long been a lot of work that's worked on the adherence front with relatively little effect, unfortunately. And this Cochrane review, basically concludes that the available methods that have impact are complex and not very effective. I hear that. I think that I want to try to look at the glass half full, though. And the fact is that we do have proven adherence interventions. They exist. And there's abundant evidence for them. And this is one review that was conducted a few years ago through, I think HRSA had put this together. Anyways, they reviewed a variety of RCTs of different kinds of interventions at different levels, patient, provider, and systems level, to see what their evidence base was across a variety of chronic conditions, excluding a few. And in the end, what they conclude is that reduced out-of-pocket expenses, case management, and patient education with behavioral support all improved adherence in more than one condition. So there are approaches, and then you look inside conditions, there's even more evidence. So there are ideas out there, there are approaches that do work. I'll just take a minute to highlight a couple here. This is an example which looks at this, the largest level in terms of thinking about how we might influence structures or systems of care. And this is a trial which was done by Nitish Chowdhury and colleagues. And what they did was they took individuals who had had a major vascular event, and then they looked at their adherence under two conditions. If they were randomized to either get free medicine without any copay, they provided full coverage for the treatment, or they paid the standard copay. And what was really interesting about this approach is that the individuals who received full coverage showed a variety of positive outcomes, at least in terms of reducing disparities around healthcare outcomes in this particular context. People who had no copays had slightly better refill adherence. It reduced vascular events in patients of color by 35%, and it actually reduced healthcare spending. And as a result of a trial like this, which was done with many thousands of patients, it actually resulted in changes in the way that many different healthcare coverage companies work in this space, and they've reduced copays to help facilitate adherence and attain these kinds of outcomes, which are helping to reduce disparities. Health approaches. I mean, it really is unbelievable where we stand today compared to even just a few years ago, much less, maybe 30. And we do have an incredibly powerful tool. For most of us, it's just, no farther than our hands or our pocket. And of course, there's a lot of interest in how you use mHealth for helping with adherence as well. This is really one of my favorite trials, actually, in this space. It was an important trial because it was the very first time that an RCT had shown that a mobile health intervention could affect a biologic treatment outcome. And for that reason, it was published in Lancet. I also like it because of the particular intervention that's used. It's patient-centered, and it's amazingly simple. What they did was they sent, among people who are initiating HIV treatment in Kenya, they sent a once-a-week text message. Not every day, not twice a day, once a week. And the message just literally said, "How are you?" And they had asked these patients to then respond to this message in one of two ways: fine or problem. And if a patient sent back a message that said problem, they would get a call from a nurse. And the nurse would talk to them about what was going on. And that might be medication related, it might have adherence related, it might have something else going on. In fact, actually, when they looked at the data, they found that a lot of times these calls, it happened very infrequently, maybe like 5% of the time. But a lot of times it was not just about one's own health, but like about the health of a family member. But people who did that for 1 year, at 1 year they had better adherence, and then they also had higher viral suppression. And so there was something about that regular contact or having that access to care that seemed to stimulate people to be more motivated about taking their medications, and it produced that biologic outcome of improved viral suppression. I think one thing that's interesting to take from this trial is that our interventions, there was the concern in the Cochrane report that most of the available ones are very complex. But I think in the case of reducing copays or sending a once-a-week automated text message with a nurse care follow-up, the interventions actually can be simple and they can have impact. Now, we're standing at the doorstep of an incredible revolution in terms of what is possible. And indeed, there are a variety of new tools that are coming aboard. How widely they'll get used and how well they'll get used is an open question. But we are at the point where there are these wireless sensors that can send very rich data on adherence back, and if there's a way to process that in a way that's useful for clinicians, then that could provide some incredible impact as far as watching people and helping them in moments where they're having challenges with adherence. There's also the Proteus pill, which we talked about this morning, and it's this microchip-enabled sensor. It's true there are real questions about the acceptability of this. I will tell you that in some early work with the Proteus pill, it was done in a patient population of schizophrenics. And the schizophrenics were okay with it. The thing that's really interesting about Proteus is both these kinds of monitors as well as Proteus is it allows for individual feedback. And I think that there's certainly some magic in having a feedback, a daily process of, or getting a weekly report of how well you're doing. Are you in the green, yellow, or red zone? And that might not solve all of the problems. Will that help with the people who've decided they don't want to take their medication? Maybe not. But it might take care of at least some of those problems, the people who are just too busy or just forgetting. So having that feedback loop could be very powerful. And then the other thing is that it doesn't have to be a complex and pricey device. There's ways to integrate this kind of stuff into care. We're talking about how EHRs could potentially be optimized to help with these things. So this is an example. It's inside of the CNICs, which is a very large cohort of HIV care clinics, which have integrated their systems. And there's a group there that's implemented a patient-reported outcomes collection, where what's happening is as patients come into the waiting room, they receive a tablet, a computer tablet, and those minutes that they spend waiting there, they just fill out a couple of quick survey questions. And one of them relates to adherence, and it includes this particular question here. And in this use in this HIV context of an HIV outpatient treatment clinic, that simple self-report question has shown some very good correspondence to viral load, to actual biologic outcomes. Does that mean that it captures every single last person who's had an adherence problem? Maybe not, but it's helpful. And that data goes immediately into the EHR so that it's available for the clinician to have when they meet with the patient. So there could be some things that are done into the care systems themselves that will help. So, in this first part of my talk, I just wanted to highlight these areas around defining and understanding and addressing adherence. And I hope that I've helped to explain how, there's still a deep need for us to work in this space as far as advancing effective interventions and improving the way that we monitor for adherence. And so now in this next part, I do want to talk about how we at NIH want to invite you to help us, help everyone, in terms of how we advance our work on this problem. And that's where our adherence network comes in. The Adherence Network is a consortium of science officers at the National Institutes of Health. I'm one of them. But really, they're drawn from 17 institutes and centers all across the NIH. And our collective efforts are really to advance HIV. I'm sorry, I betray my origins. It's bigger than HIV, much bigger. There's 17 institutes that are involved. NIH-sponsored adherence research. And so we've done a whole variety of things. We have a webinar series. Some of you may have caught our webinar with Bernard Regions, which was just last week. And we're holding meetings, and we're identifying opportunities for funding and so forth. One of those things that we've done is to prepare a funding opportunity, and this one is called Advancing Interventions to Improve Medication Adherence. It is not the only funding opportunity for adherence at NIH. If you go to the website, you just Google NIH Guide, and that's where all of these opportunities are listed. And if you get to the NIH Guide and you type in adherence, what you'll find is there's 16 opportunities right now inviting adherence research in a variety of areas. But one of them is this announcement. And this announcement, which comes from our adherence network, is asking for research applications that would spur the testing of interventions to improve medication adherence. And that might be in one chronic condition, it might be to prevent disease, or it could even be for multiple comorbid conditions. The call for this research really extends to a whole wide variety of approaches, along that ecologic model. That includes, some of the technologic approaches, like we highlighted here, other efforts to address health literacy. We have the Complementary and Integrative Institute is interested in mindfulness approaches to improving adherence. Peer, lay health worker, social support approaches, there's a whole range. And that extends to other efforts, which include more targeted efforts. Can we advance interventions that might reduce racial and ethnic disparities in this domain? Or use screening tools to help us target who should be receiving more support? And then it extends to also large-scale approaches, kind of systems approaches, pharmacy-based, institutional level interventions, multi-level interventions, and even population-based approaches. So it's pretty broad. The requirement for this announcement is that you do have multiple measures of adherence inside of the research proposal, but they can vary in a variety of ways. You can include self-reports, but you have to have at least one non-self-report measure. So that might be claims data, it might be electronic monitoring. There's a few different ways that could happen. And we do encourage people to look for biomarkers too. Where possible, we want to see whether an adherence intervention can potentially affect a biologic outcome, glycemic control, HIV viral load, and so forth. There's another companion announcement. That's for R01 projects. Those are larger projects. There's an R21 version of this, and that's for a smaller study, which would is really often very good for doing some preliminary work around determinants or to develop and pilot test interventions. And it has the same parameters as before. And this is the part where everybody will get a copy of these slides, and so you'll have all of this detail to look at later. I'm now going to fly through the detail and just say that there's a whole set of institutes that have a set of research interests that they've articulated in this particular announcement. NCI is participating, and they have a set of priorities. I won't read them here. There's a variety of people you can talk to at NCI about your interests in adherence. Susan Schakowsky has just moved to NCI, Wendy Nelson, our colleagues Erica Breslau and Janet Damore. Here's the National Eye Institute, which also has interests in adherence. Ellie Schron is our contact there. NHLBI, working on aspects of cardiovascular health. Our contact there is Peter Kaufman. The National Institute on Alcohol Abuse and Alcoholism is interested in work addressing adherence to treatments for alcohol use disorders. Brett Hagman is our contact. NIDA, the National Institute on Drug Abuse, also interested in this space. Will Akin is our contact there. The Diabetes Institute is looking at this kind of issue, and Christine Hunter is our contact. NIMH, working both in HIV and in mental disorders, and that's represented by my colleague Susan Azrin as well as myself. And then NINR, the Nursing Institute, we have contacts there in Donna Jo McCloskey and Karen Huss. And in the slides, you'll have an opportunity to take a closer look at the individual interests of the institutes. And right now, there's also the Center on Complementary and Integrative Health. That's our group that's interested in mindfulness approaches, as well as the NIDCD, which is looking at conditions related to hearing and speech. Our slides include a small set of grant writing tips that I won't go into now, but hopefully they're helpful to you. And I would just say that if there was one thing, we've given you a whole set of contacts here that you might reach out to about your ideas. It's really great to reach out to us. Write up a concept, a short concept, send it to one of these people, and ask for a call so that they could talk to you about whether the concept corresponds to the priorities, the mission of their institute, and they'll give you some good advice around how best to proceed. But a few other resources here. I think I'll just close then by saying that I'm really delighted to see such interest in this space. We do have a lot of important work to do, and it's not going to happen unless we all work together to do that. We're stand ready to help you in facilitating your research, and I look forward to our continued conversations. So thank you so much.